Hello, I'm Dr. Stephen Silberstein, professor of neurology at Thomas Jefferson University in Philadelphia. Welcome to this program titled Dihydroergotamine for Acute Migraine Treatment, Current and Emerging Approaches. Migraine is one of the most prevalent neurological conditions worldwide. It's a leading cause of disability. It's underdiagnosed and it's often undermanaged in patients who are diagnosed. Let's talk a bit about the pathophysiology of migraine. And we created this slide to show not only the fact that migraine is a disorder of the brain, but what its impact is. There's 36 million sufferers in the United States. Triggers include hormones. There's light sensitivity, throbbing pain, visual disturbances. 10% of school children are affected. This is not a disorder of hysteric women. This is a dysfunctional disorder of the brain that I'll talk about in just a moment. What are the phases of migraine? First, before the headache begins, the premonitory symptoms. One can have neck pain, fatigue, mood changes, light sensitivity, sound sensitivity, and nausea. One can have food cravings. We'll say that triggered my migraine, but it's the migraine that made them eat the food. After that can be the aura, visual changes, numbness, weakness. Following that is a headache and something called cutaneous allodynia, which means that non-painful stimuli appear painful. And then lastly, after it's over, you're washed out. It's like you have a hangover, and that is called the postdrome. Let's look at a bit at the pathophysiology of the migraine attack. The premonitory symptoms begin in the hypothalamus. This results in triggering the trigeminal nucleus caudalis, which is the brainstem center for pain from the face. This results in the activation of the trigeminal ganglion, resulting in CGRP release, vasodilatation, activation of the C fibers and A delta fibers, and basically information of pain goes back into the brainstem. So migraine is a disorder of the brain with a genetic basis. Early series linked cranial vasodilatation to migraine pain. But vasodilatation is neither necessary nor sufficient for the symptoms of migraine to occur. I tell my patient if they had a seizure and the right arm shook and the blood vessels dilated, that's the result of, not a cause of the seizure. Neuronal theories are involving the central or peripheral nervous system are now the focus of migraine pathophysiology. And there are multiple brain regions that generate migraine symptoms and the overlapping phases of migraine. Next, let's talk about DHE. It was approved in 1946 and continues to be used today for the treatment of acute migraine. What are the benefits of systemic DHE? It can be used early or late in the attack. It works quickly. Its effects last up to 48 hours. It's often effective in patients resistant to triptans, and different formulations approved and in clinical trials for the acute treatment of migraine. The chemical structure of DHE is similar to naturally occurring neurotransmitters like epinephrine, norepinephrine, dopamine, and serotonin. In fact, its main site of action is on the serotonin 1B and 1D receptors. This reduces trigeminal neuron activation. In addition, the activation of the 1B receptor induces vasoconstriction of meningeal blood vessels. Other receptors activated include the serotonin 1A, 2A, F, 2C, 3, noradrenaline, and dopamine receptors, giving DHE activity at other receptors and account for its better and continued sustained effect during any time during the migraine attack. Its long terminal half-life, IV or IM, about 9 hours, intranasal 10 hours. But more important, its biological half-life is 2 days. So even after it's gone from the blood, it's still working on the tissues. What are the formulations of DHE? They're limited to non-oral formulations. The absorption in the gut ranges from 10 to 60%. There's poor oral bioavailability, about 1% or less. Intravenous DHE requires administration by a healthcare provider. Subcutaneous and IM injection is challenging to self-administer. DHE nasal spray is currently available, has variable absorption. A novel intranasal formulation of DHE, which I'll talk about, shows better bioavailability. IV DHE. It's the fastest and most effective route. It's often used when other treatments fail. It's administered intermittent or bolus injections, typically 1 milligram every 8 hours for 1 to 3 days in refractory migraine, 97% pain reduction, 60 to 78% pain freedom. High peak plasma concentrations result in more systemic side effects than other formulations. Therefore, it's often given with an antiemetic, and the IV formulation can only be used in the emergency room or by headache specialists. If you look at the subcutaneous or IM injection, the maximum concentration is reached in about 34 minutes. IM DHE metoclopramide, 2-hour pain relief within half of patients versus 40% with valproate. Subcutaneous DHE, 2-hour pain relief in 70% of patients versus 85% with sumatriptan. However, the recurrence rate with sumatriptan was double that of DHE. IM and subcutaneous efficacy are limited. Concomitant antiemetics are often needed, and many patients have needle phobia. DHE nasal spray was approved in December 1997 as a non-injectable version of DHE to overcome the limitations of IV administration. It is indicated for the acute treatment of migraine with or without aura. Nasal spray contains DHE mesylate and other compounds in water. It targets the lower nasal cavity. Its bioavailability is 32% of the amount given. There's variable absorption. Spillage can occur when the spray runs out onto the upper lip or down the back of the nose, the nasopharynx, and the differences in self-absorption between users. And a randomized double-blind controlled studies were done to look at the efficacy of DHE nasal spray. These studies used headache response as a measure of efficacy rather than pain freedom. Headache response was assessed at 2 and 4 hours in individuals receiving nasal spray or placebo. Only one of the studies showed significant results at 2 hours for the DHE nasal spray compared to placebo. At 2 hours, the DHE nasal spray was 61% versus 23% for placebo. In that same study, 4-hour response was 70% for active drug and 28% for placebo. 2 other studies showed significant results at 4 hours in terms of headache response for DHE versus placebo, with rates of 56 and 48 compared with 35 and 22 respectively for placebo. The therapeutic gain above 25% in only one study of DHE nasal spray. At 2 hours, the highest was 38%. At 4 hours, the highest was 42%. The lower nasal cavity is the therapeutic target. Nasal cavity is proposed as the entry point for therapeutics into the systemic circulation. Most agents that are delivered that way target the lower nasal cavity. Targeting the lower nasal cavity typically results in lower systemic bioavailability due to the presence of thick, ciliated, pseudostratified columnar epithelium plus a layer of mucus. Systemic absorption was neither sought nor desired with traditional nasal sprays because they were for treating disorders of the nose like allergic rhinitis. Let's look at the upper nasal cavity as a therapeutic target. It's thinner, highly vascularized, olfactory epithelium with good tissue permeability and avoidance of the first pass hepatic metabolism. Drug delivery by the upper nasal cavity may lead to more consistent and predictable systemic absorption than via the lower nasal cavity, and delivery to the olfactory epithelium deeper in the nose may reduce the likelihood of the drug dipping out of the front of the nose or down the back of the throat. Look at the deposition of DHE in the nasal cavity using the pod device compared with a nasal spray pump. The pod deposited the highest percentage of DHE in the upper nasal region, followed by the lower nasal region, the vestibule, and the nasopharynx, respectively. The pump deposited most of the DHE in the vestibule, then the lower nasal and upper nasal regions, and the nasopharynx, respectively. A more reproducible delivery is seen with IMP 104 compared with the typical DHE nasal spray. Let's look at the plasma DHE concentrations following the administration of single doses of IMP 104, IV DHE, and DHE nasal spray. A 1.45 milligram dose of IMP 104 had a peak plasma concentration similar to 1 milligram of IV DHE from 30 minutes after delivery up to 48 hours. Lower plasma concentrations were observed for the DHE nasal spray compared with IV DHE and IMP 104 at all time points up to 48 hours. So let's look at IMP 104. It was recently FDA approved for the acute treatment of migraine. It uses the same DHE formulation as the currently available nasal spray. With the use of the device, DHE is delivered to the upper nasal region above the middle turbinate. Bioavailability is close to 60% versus 15% for the approved DHE nasal spray. Let's look at the STOP 301 study. IMP 104 is a novel drug device system targeting the drug to the upper nasal space. A phase 3 open label 52-week study was done, 24-week safety study, and a 28-week extension period. The primary objective was to assess the safety and tolerability of IMP 104. Exploratory objectives included efficacy assessments of migraine measures and a patient acceptability questionnaire. Patients with a documented diagnosis of migraine using the International Classification of Headache Disorders criteria. They had to have more than 2 attacks per month, with less than 14 headache days per month for the past 6 months and during the 28-day screening period prior to the second visit. Patients took their best usual care during the 28-day screening period, and medications used included acetaminophen, nonsteroidals, triptans, and combination analgesics. 360 patients entered the 24-week treatment period. 354 patients received dosing at least once. IMP 104 was dispensed every 4 weeks in a 24-week treatment period, and then at weeks 24, 36, and 42 in the extension period. Patients self-administered IMP 104, 1.45 milligrams, even when they had a migraine pain, even with mild. The electronic diary was used to capture information on the headache that occurred, when it occurred, and the treatment used. Dosing was limited up to 2 doses every 24 hours and up to 3 doses every 7 days. IMP 104 is well tolerated in the 24-week safety study. 68.1% of the patients reported treatment emergent AEs. Most common were nasal congestion, nausea, nasal discomfort, and abnormal taste. 2 hours after a single dose in the first study drug treated attack, 38% of patients self-reported pain freedom. 52.1% of patients reported freedom from their most bothersome symptoms. Compared with the best usual care at baseline, 2 hours after a single dose, 31% of patients had freedom from pain, and 46% of patients self-reported freedom from most bothersome symptoms. This is the data, pain relief for the first treated migraine attack, starting at quarter of an hour, 16%, half an hour, 29%, 1 hour, 47.6, 2 hours, 66.3% of the patient. STS-101 is a powder formulation of DHE, nasal delivery, squeeze bottle device, one-way valve, and currently in phase 3 trials. In a 2-part active controlled 3-period crossover study conducted over 3 weeks and separated by a 1-week washout. Participants were healthy adults without a history of migraine. Part 1, 15 patients received 1.3, 2.6, and 5.2 milligrams in ascending order. Part 2, 27 patients received 1 dose each of STS-101, 5.2, DHE nasal spray, and IM DHE 1 milligram in randomized order. This is the data comparing the 3 different modes of administration. If you look at the very bottom, that's the time and concentration of the liquid nasal spray. At the top is IM DHE. In the middle is the STS-101 formulation, which is clearly superior to liquid nasal spray, but doesn't show the same peak values or the same Cmax as the injectable DHE. What are the phase 1 safety? As expected, dysgeusia, nasal congestion, nasal discomfort, nasal pruritus, rhinalgia, rhinorrhea, and sneezing. Safety concerns. Serious or life-threatening peripheral ischemia associated with administration, DHE with CYP3A4 inhibitors can cause problems. Should not be given to patients with ischemic heart disease, symptoms of finding of coronary artery vasospasm, uncontrolled hypertension, or peripheral arterial disease. It should not be given to patients whose sepsis is severely impaired renal or hepatic function. Well, let's look at the characteristics of a beneficial treatment for migraine. It needs to be fast acting so patients get immediate relief. It needs to be taken at any time during the attack, not just while the pain is mild. It needs to be able to relieve all the symptoms of migraine, including photophobia and nausea. It should have lasting relief without recurrence. It should provide complete or near complete relief from the symptoms. It should have few or minor side effects. It should have low-cost insurance coverage. And you should have the ability to take the medication, and it should not interfere with your regular activities. Now that the intranasal formulation is available, when do I use DHE? DHE in the infusion center in the hospital is our mainstay of treating migraine. However, until now, the current formulations of nasal DHE were not effective enough for me. But with the use and the approval of the new pod formulation of DHE, I have an option. Patients are taking too many drugs on a daily basis. It's no longer working. DHE will work. Patients with menstrual migraine, perhaps at the beginning of the period, since it lasts for 48 hours. Patients in whom the usual drugs don't work are intractable. Patients with cluster headache, it's not approved for it, so I'm talking off label, but we've always used DHE for cluster. To me, it's an important, significant addition to the treatment of migraine.
Let's explore the use of DHE in actual clinical practice. And actually, let's look at some cases. The first case is a 37-year-old man who's looking for better relief of his headache pain. The patient moved to the area about 4 months ago and ran out of his prescription for sumatriptan. He's here interested in a refill. It typically gets 4 to 5 migraine attacks per month. He describes his headache as a stabbing pain of moderate to severe intensity, usually above the right eye. He also has sensitivity to light, sound, and also nausea. Stabbing pain is not the typical pain of migraine, it's usually throbbing, but it's moderate to severe in intensity. It's one-sided, and he has the associated features, which makes it migraine. His examination is normal, and he has no cardiac risk factors. The patient returns about 6 weeks later. He expresses concern he's not receiving complete pain relief from the triptan he's getting, even when he takes a second dose of the medication. The patient reveals that he has not been taking the first dose of amitriptan as quickly as he was before. Since this medication can make him feel drowsy, he waits until after his commute home to take it. This was not an issue with his previous place of employment, as he worked out of a home office. What would I do? I would consider the use of DHE nasal spray. How is it given? One spray in each nostril, which can be repeated after an hour. And the patient should be instructed not to administer more than 2 doses or 4 sprays within a period of 24 hours and no more than 3 doses within 7 days. Now, why would I use DHE pod before I go on to the second case? 1, it's quick acting. 2, DHE is long acting. What do I mean by that? The half-life is biological half-life is several days. And unlike the triptans, the headache doesn't come back. So it's a very good choice for him. Case 2, menstrual migraine. A 22-year-old woman presents with a complaint of headache. These headaches began when she was a teenager, and they were easily managed with an over-the-counter analgesic. However, over the past 6 to 8 months, headache intensity has increased, and her over-the-counter medications often do not help or alleviate her headache pain. She's missed work or canceled plans with friends because of her headache. She describes the pain as throbbing, one of the criteria of migraine, above one eye, unilateral, and moderate to severe intensity. All of them are migraine features. When asked about the frequency of these headaches, she states that she believes they occur mainly around the time of menses. A tentative diagnosis of menstrual migraine is made. She receives a prescription for a triptan. She is asked to keep a prospective headache and menstruation diary over the next 3 months. Per the International Headache Society criteria, menstrual migraine with or without aura can be subdivided into pure menstrual migraine and menstrually related migraine. Pure menstrual migraine is classified as attacks that occur between -2 and +3 days of menstruation, and at least 2 out of 3 consecutive menstrual cycles. But most importantly, there is no migraine at any other time of the cycle. Menstrual related migraine is similar, but attacks occur at other times in the cycle. Per the international classification, diary evidence is no longer required to make a clinical diagnosis of menstrual migraine. A prospective headache and menstruation diary is used for research purposes. However, an accurate diagnosis is important for providing effective treatments for migraine. At the follow-up visit, 3 months later, her diary reveals that her headaches, which are the migraine type, only occur 1 day before to 2 days after the onset of menstruation. Therefore, a diagnosis of pure menstrual migraine is made. The triptan medication provided relief from the migraine pain, but she had to take more than 1 dose on all days of her menstrual cycle. She asked, is there another medication that may relieve her migraine pain more effectively? In 1996, we did a study that found that nasal DHE was effective to abort menstrual migraine. In general, DHE is less recurrence than a triptan, less than half. DHE works at any time during a migraine attack, and the effect is long lasting. It sticks to the receptor. Based on this, I recommended the DHE nasal spray, which has good bioavailability. And she doesn't have to worry about repeat dosing and less recurrence. In summary, I'd like to talk about the difference between DHA and triptans. DHA is an older drug, but it has different properties. First, taking too many triptans can result in the production of medication overuse headache. We use DHE to wash out the triptans and treat medication overuse headache. Secondly, we have found that DHE works anytime during the attack, whereas if you take a triptan, if you don't get it early enough, it may not be effective. The third major point is duration. DHE sticks to its receptor for several days, which means a single dose continues to work. And this means that, while with a triptan, sometimes 30 or 40% of the patients, the headache comes back in 24 hours. But with DHA, that does not happen. So what I then do is patients who have headache that doesn't respond to triptans, patients who headache recurs, or patients who cannot get early enough treatment. I think an appropriate treatment for these patients is DHE.
So, what are the take home messages? DHE for acute migraine is limited to non oral formulations. IV formulations can only be used in the ER by headache specialists. Efficacy with a subcutaneous intramuscular injection is limited due to the challenges of administration. There's variable absorption from the current DHE nasal spray. IMP 104, an intranasal formulation of DHE, is now FDA approved. I want to thank you for participating in this activity. Please continue on to answer the questions that follow and complete the evaluation.